This will be a rapid overview of CO2, and if you're interested, on Friday we do have a half-day course that will describe it much less fast and more comprehensive. But anyway, the role of CO2 angiography in improving healthcare and decreasing costs, and where's the cheap gas? Okay, so the disclosures are: I'm a consultant for Angio Advancements, who manufactures one of the new delivery devices for CO2. I direct you to co2angio.org, and that's .org, where you can see multiple videos regarding CO2, as well as over 400 PDFs regarding the different types of CO2 and where it can be used. Or you can email me, which I get emailed quite often at jimcaridi@gmail.com. So the gas has unique properties. It's invisible, it's buoyant, it's low viscosity, and it's compressible. And that affords us a ton of advantages over iodinated contrast. It's non-allergic, it's non-nephrotoxic, it's rapidly absorbed. The low viscosity feature is great in PVD, in that you can inject through microcatheters, you can inject around the wire with the catheter in place, never having to remove the wire. You have better visualization of collaterals, detection of bleeding, AV fistulas, and then for some of us, portal vein visualization. Another feature that is great is central reflux. You know, if you have a catheter tip and you inject contrast, it goes peripheral. With the CO2, it will actually reflux centrally and can show you all the other vessels, as well as possibly a culprit lesion that you crossed, and you want to know exactly where that is before you deploy a stent. And then, of course, there's the cost. 100 cc's is about 3 cents. There have been CO2 concerns, which I'm not going to get into today, but contamination, excessive volumes, intracerebral exposure, compressive delivery, COPD, and pulmonary hypertension. But with a little bit of knowledge, you can eliminate those. And the only contraindications we have with CO2 are arterial injections above the diaphragm and pulmonary hypertension with a known patent foramen ovale. And I say this is theoretical and has never really been described in the literature. Now, here's the indications. There are many: iodinated contrast allergy, renal insufficiency, high volume contrast procedures, arterial and venous diagnosis and intervention, detection of bleeding and AVF, dialysis, interventional oncology, portal venography, tips. It really is up to your imagination what you can use it for. The advantages translate into this: better health care, earlier diagnosis and treatment, less morbidity, mortality, and of course, less cost. Now, one thing people don't realize, aside from angiography, we can use CO2 in any tubular structure. And here's a CT, T-tube, cholangiogram, and a nephrostogram, and we can use those in patients who show up and are allergic to contrast. Now, the way we got the fame for, and the initial fame for CO2 is that it was non-nephrotoxic. It is the only contrast that's non-nephrotoxic. And we know that we have contrast-induced nephropathy risks. And if you look at this list, which I won't read through, if you look at this list, how many of your patients don't have one or many of these comorbidities? And basically, most of our patients are set up for contrast-induced nephropathy. And we know with renal insufficiency that, and a lot of radiologists will tell you this, oh, we're just going to send them to dialysis. By the time they make it to dialysis, think of how many times that contrast has gone through the kidneys, and it's really a misimpression that you can get rid of this contrast through dialysis. And if you look at the residual GFR in a lot of these patients, a drop of 1 point in the GFR increases the mortality of these patients by 12%. So some of the articles that have been out, hospital-acquired CNN, increases the risk of death 6 times, and that extends out over the years of 1 or 2 mortality twice. Another article, 7,500 patients, the in-hospital mortality was 22% versus 1.4%, and again, it extends out over the years. This was a consortium of patients with Blue Cross Blue Shield who had endovascular procedures, and the contrast-induced nephropathy was 3%, had 25 to 40-fold increase in in-hospital death, and the hospital stay was 3 times longer. If you just get contrast-induced nephropathy without dialysis, your hospital stay is longer, and it costs you about $11,000. And if you look at the hospital list, they reported an acute kidney injury cost the United States healthcare $9 billion annually, and the incidence has jumped 6-fold in a decade, and the mortality rate and the hospitalization rates are increased. So dialysis, again, is too late to negate the negative effects of contrast on the kidneys. And the bottom line is to reduce or prevent contrast-induced nephropathy, which is very costly, is to limit the volume of contrast. And this is what we say at Tulane, that what good is if you help them walk and now they have to walk to dialysis. So CO2 imaging not only eliminates contrast-induced nephropathy, and if you listen to Craig Walker, he'll tell you the same thing, it permits procedures on those patients that were previously precluded from having the procedures done. So we have a whole new group of patients that we can use or perform procedures on because we can use contrast. We can use it for arterial diagnosis and intervention. It affects 27 million people in PVD affects 27 million people in Europe and North America. That's 16% of the population. The numbers are increasing because of comorbidities. The 4-year increase in peripheral arterial disease is 20%. The endovascular procedures for these patients has increased 46%. They have a whole host of comorbidities. Their creatinine clearance and their creatinine are abnormal in a lot of these patients, and we have to be very concerned because contrast-induced nephropathy increases the hospital stay and 1-year mortality as well as the cost. This is using a 3 French catheter to do a runoff. Of course, I showed you the pretty pictures, but we can also see the abnormal feet in this case. Here's another area to use it, and the patients have elevated creatinine. They just got a renal transplant. You don't want to put contrast in here because you could kill the renal transplant that they've been waiting for. You can do the entire procedure with CO2 because, remember, CO2 is buoyant. The artery is placed anteriorly, and we can do the entire procedure using CO2. CO2 and CLI and CTO, the size of the vessels are ideal. There's little soft tissue interface, and CO2 can be used as a roadmap because all the way down. Now, some people will say, well, I use CO2 when I get down to the foot, if I use too much contrast. Why not start with CO2, get down to the area of involvement, and if you have a problem, you can use a little bit of dilute contrast to see what you need to see. We can use it in small catheters, 2 French or less, and then the opacification from reflux. If you inject in one of these small foot vessels, it'll reflux back and show you more than just the artery that you're in. This is just an example of CO2 on top and contrast on the bottom. Now, we can detect bleeding because of the low viscosity in some of these patients. In this case here, the patient got hypotensive. They didn't know why. They used contrast, couldn't find it. CO2 at the aortic bifurcation shows an AV fistula. There was a small fistula from the puncture, and this was treated with a stent graft. You can use it in EVARs. These patients have a predisposition to renal insufficiency, anywhere from 7 to 25%, whether they have contrast-induced or whether they have renal insufficiency or not. If those patients get to go on dialysis, that contrast-induced nephropathy has a mortality of 30 to 50%. This is showing some of the vascular surgeons and cardiologists now use CO2 primarily as their contrast agent in EVARs. And then because of the low viscosity, you can even detect endoleaks that were not detectable by contrast. I think it is the primary and the best contrast for venous studies because, remember, we're displacing the blood. We're not mixing with blood as with contrast, and you can inject in the extremities and see the central circulation. So we can use it for extremities upper and lower. I use CO2 for all my filter placements, dialysis, tips, and portal vein. This is just 25 gauge needles in the hand, just requires alcohol. You don't have to prep. There's no muss, no fuss. You can see the extremity veins and also centrally, and the central circulation is good. Another thing, if you're planning to do a dialysis catheter intervention in the neck and you don't know what the anatomy is, a simple injection in the hand, because of the low viscosity, will show you the central circulation and will cross midline because of the low viscosity and give you a landmark before you start sticking this patient. This is a friend of mine, a professor in Italy, who did cardiac resynchronization treatment and found that she had a 10% incidence of contrast-induced nephropathy. And when she looked at it, there was increased mortality in those patients that got CIN, and now she uses CO2 primarily just from a hand vein, looking at the central circulation before she does any intervention. This is for IVC filters. We can use it for dialysis. This is dialysis declot. There are some caveats with dialysis that you have to be aware of before you're using dialysis. And just remember, if the patient comes in and has some renal function, you don't want to destroy that function because if you decrease their GFR, you increase their mortality. So in summary, CO2 angiography prevents costly and debilitating renal complications. It permits procedures on patients that we used to say, we can't do this, you have to go home, and now we can do them, and quality of life or life-prolonging procedures. And assists to make diagnosis previously missed by iodinated contrast and eliminates additional procedures. It's safe, and most of all, it's inexpensive. Thank you very much.